Mhm.
All right. I think it's safe to go ahead and get started, and we will just keep an eye out
Mm.
for anyone that is coming in.
Sounds good.
Okay, so just to give a little housekeeping stuff before we get started, I've said this a couple of times.
Yes.
That stuff's gonna get cut out. Um, Questions. Any questions that you guys have, drop them in the chat. I will be moderating the chat, and all of them will get answered at the end. We'll make sure we take care of them at the end. And also, this is currently being recorded. It's going to get sent out to all almost 200 people that did sign up for this. So if you don't want to be seen, feel free just to keep yourself muted and picture off. And that is that. You made it to Pelvic Health 101. This is the first of the Centrality free series of webinars that we are doing, which we'll touch more on that at the end of this. Sheron will be leading this, but I'm going to introduce the both of us and then let her take it away. So, Pelvic Health PT.
All right. Thank you. Thank you for that wonderful introduction, Jen. Welcome, everybody. Thank you for joining us this evening on Pelvic Health 101. I am so grateful that you are here, and I'm so excited to be hosting this webinar. I'm a pelvic health physical therapist, and I work at Centrality Physical Therapy and Wellness. So let's get started. Today's objectives are, one, to provide you an overview of the anatomy and the function of the pelvic floor muscles and their role in bowel, bladder, and sexual function. But also it is to increase awareness about common pelvic health conditions. I get these questions very commonly, and I'm sure my other pelvic health therapists will agree with me, but we get questions about or comments asking, why wasn't I told about this before? Why wasn't I referred to pelvic health before? I wish I knew about this earlier. So my goal for us today is to empower all of you to take an active role in your own pelvic health, to be able to effectively advocate for yourselves and navigate this crazy healthcare system that we have. And more importantly, I would also like to reduce the stigma that's associated with pelvic health conditions and encourage open communication about these topics between you, your friends, your loved ones, your family members, because you might be helping them understand that they could be helped, right? These conditions are so much more common than you would think. All right, so let's go into understanding what is pelvic health rehabilitation. So pelvic rehab is a non-surgical approach to treating pelvic conditions using strategies like exercises, behavioral modifications, lifestyle modifications, lots and lots of education, manual therapy, and so much more. Our basic goal is to help improve strength, flexibility, coordination of your pelvic floor muscles, as well as the structures that are above your pelvis and below your pelvis. But of course, your focus is on the pelvis. Now, your pelvic health providers could be your urologists, your OBGYNs, your urogynecologists, your colorectal surgeons, your proctologists, as well as your pelvic pain management specialists. And in the rehab realm, your pelvic health providers would be your physical therapists and your occupational therapists. So coming to a question, who do we treat, right? We treat all humans, everybody. If you have a pelvis, we are here to treat you. So no discrimination. But for the purpose of today's webinar, we're going to focus on women's pelvic health. And I will be hosting a male pelvic health webinar on June 13th. And my wonderful colleague Janelle is hosting a pediatric pelvic health webinar on July 11th. And all of this information, if you would like to sign up, will be put at the end of this webinar. So please feel free to sign up if this is something that you would like to know more about. All right, so what is your pelvic floor? Your pelvic floor is made up of 3 layers of muscles, ligaments, and connective tissues. Now, your pelvic floor forms a sling at the base of your pelvis, so starting at the pubic bone in the front, going all the way back to the tailbone, and on the sides between your 2 hip bones. They are responsible for supporting your pelvic organs, which is your bladder, your uterus, or your prostate, and your rectum. And they provide stability to your spine as well as your pelvis, and also helps maintain posture and balance. Most importantly, your pelvic floor works with your diaphragm to help manage intra-abdominal pressure. So during movement, this is highly, highly important. Now, moving on to discussing the anatomy of your pelvic floor. So as I've said before, pelvic floor made up of 3 layers, right? So the first layer is the superficial, most outermost layer. And on the slide, we have the male pelvic floor on the left and the female pelvic floor on the right. So as you can see, the muscles are pretty much the same, right? It's just oriented a little bit differently. So in the male pelvic floor, we have the penis, we have the base of the penis, we have the transverse perineal membrane, and then we have the anus and the external anal sphincter. In the female pelvic floor, we have your vulva, which houses your clitoris, your urethra, your vaginal canal. Then we have your transverse perineum, external anal sphincter, and your anus. Now, this layer is responsible for sexual function as well as keeping your poop and pee inside, unless you're ready to evacuate. Now, going to layer 2. Layer 2 basically houses your urethral sphincter. So it provides you further support. It provides your urethra further support in preventing you from leaking during any exertional activities, right? So definitely works with your layer 1. And now moving to the deepermost layer, which is your pelvic, which is layer 3. It's also called your pelvic diaphragm. Now, this layer is responsible to stabilize your spine, your pelvis. It is a supportive structure for all your wonderful pelvic organs. So definitely needs to be strong, needs to be mobile, right? And now we move on to looking at a split side view of the pelvic cavity. So on your left, you have the female pelvic cavity, which houses your bladder, and you have your urethra. We have your uterus and your vaginal canal. And then all the way at the back, we have your rectum. And on the male pelvic floor, we have your bladder. Sitting right underneath is the prostate. Going through the prostate is your urethra. And then all the way at the back is your rectum, right? And then moving to yes. So talking about, now that we've covered the anatomy, the basic anatomy, we'll look at the function of the pelvic floor. And I've possibly mentioned some of them already, but just to repeat them, we have the first one is sphincteric control. So your pelvic floor has your urethral sphincter and your anal sphincter to keep your poo and pee in. And of course, your pelvic floor functions plays an important role with sexual function. It helps support your pelvic organs. It stabilizes your pelvis by working with your core, working with your hips, working with your rib cage, working with all these muscles that are above and below your pelvis for stability, for support, for you to be able to function with your daily activities. And the last function of the pelvic floor is sump pump. So the sump pump mechanism is basically your pelvic floor muscles pumping back blood and lymph all the way back up to the heart to prevent any pelvic congestion. So here we have your core canister. Yeah, a very important structure and very important to manage intra-abdominal pressure. So we have your diaphragm that sits on the top, your pelvic floor that sits on the bottom. When you inhale, the structure moves down together, and when you exhale, it goes up to baseline. If for some reason we have a tight pelvic floor or even a weak pelvic floor, and we don't have good coordination of the diaphragm and the pelvic floor, that can create so many issues which your therapist can work with you to treat. All right, so now that we've covered function and anatomy of the pelvic floor, we're going to move to understanding what, as pelvic health therapists, do we treat and how we can help you. So moving on to the bladder, right? So the bladder, a healthy bladder function is basically a bladder that can hold up to 400 to 600 milliliters of urine, right? So in a day, the normal amount of times that you could go pee is about once every 2 to 4 hours. And at night, if you're above the age of 65, waking up 1 to 2 times is considered normal. And if you're below the age of 65, waking up about 1 time is considered normal. But the main thing is no leaking, right? Contrary to popular belief, leaking is not normal. Leaking is not normal. So please seek help if you are leaking. Whether you're even running or coughing or laughing, you shouldn't leak. You should be able to live your life. Okay, so common conditions that we do see when we treat the bladder are urinary incontinence. So that's leaking, as I've talked about a little bit before, leaking with coughing, laughing, bending and picking something up, jumping. Maybe you get a strong urge to pee and you're not able to reach the restroom on time. So all of these can be treated. We can treat urgency and frequency. If you've had a painful bladder syndrome, if you have any delayed or difficulty starting to urinate, you have any incomplete emptying, like you go to pee and then again in 2 minutes, you're like, oh, why do I have a strong urge to pee again? What's going on? You can have some pain in your urethra. Also constantly waking up at night to pee. So if you can relate to any of these conditions, please seek help. Now, moving on to bowel. So a healthy bowel movement is basically somebody that can go about have 1 to 3 bowel movements a day, or about 3 bowel movements a week. The main thing is consistency. You want a type 4 consistency on the Bristol stool chart. So if you don't know what the Bristol stool chart is, it's coming up on the next slide. So you're going to get some images of some consistency of poop. But coming back to type 4, you want it to be soft, you want it to be smooth and long, one big piece, like a sausage. You should not have any discomfort when you go poop. You should not have any cramping. You should not have any pain. There should be minimal to no straining or pushing, right? Nothing. We want our body to do what it's designed to do. You want to be able to have a complete evacuation, so no incomplete emptying, and of course, no blood in your stools. So this is the Bristol stool chart. Type 4 is considered normal. Type 3 is also considered towards being normal, but anything above that is more of a hard stool and considered constipation. Anything below that, so type 5, 6, and 7, moves over to more of liquidy stools. And that's definitely something that we do not want. So common conditions that we do see with pelvic health therapy is fecal leaking, right? Urgency, pain with pooping, constipation, diarrhea, irritable bowel syndromes, anal fissures. That is so common. Hemorrhoids is so common. All of hemorrhoids and anal fissures could be because you have a tight pelvic floor. We might need to do a rectal examination to understand what your pelvic floor muscles feel like, what they are doing. So again, so many wonderful, wonderful things that a pelvic floor therapist can help you with these conditions. Okay, another important function of our lives is where, sex is a physiological function of our daily life. And we can have pain with intercourse. We can have maybe inability to have an orgasm. We can possibly have weak orgasms. We could possibly be suffering from vaginismus. Vaginismus is when your muscles around your vaginal canal, they guard as soon as there is a possibility or an insertion happening, they just guard and causes a lot of pain. You can erectile dysfunction, all of these things. This is definitely not an exhaustive list, but some of the most important things that we do see in pelvic health therapy, and sex should not be painful, right? And we can treat you. Now, moving on to things that we see or issues that we see when we are not able to regulate our intra-abdominal pressure. Prolapse. Prolapse is so common. Diastasis recti and leaking. We're definitely going to talk about these, the prolapse and diastasis recti in the upcoming slides, but just understand this is a pressure management issue. So what's prolapse? Prolapse is when one or more of your pelvic organs, so either your bladder, either your uterus or your rectum, it either bulges towards the canal, your vaginal canal, or comes out of your vaginal canal. And they can be of different grades depending on the descent of the pelvic organs. Now, symptoms would feel like pressure, increased pressure in your pelvic floor, difficulty having a bowel movement. Maybe it feels like you're sitting on a golf ball. You can have even difficulty urinating, and you can also have pain with intercourse. And this normally could happen when your pelvic floor muscles are weak or lax. Now, moving on to diastasis recti, this is the excessive widening of your two six-pack muscles, right? So they're connected together via a connective tissue called the linea alba. And when that gets stretched, we have the separation of these muscles. And when symptoms that are associated with this are bulging, or you might see coning or doming with any kind of increase in abdominal pressure, meaning even if you want to get up from a laying down position, right? If you want to sit up from a laying down position, if you're coughing, this could increase intra-abdominal pressure. And if you don't have that support from the front, that could cause that doming. Here we have a few variations of diastasis recti. So as you can see, you could either have it around your belly button. It could be below the belly button. It could be above the belly button, or it could just span the entire length of the linea alba. Now, how can pelvic health therapists help during pregnancy? We can absolutely help navigate all the biomechanical and hormonal changes that one can experience during their pregnancy journey. And the common conditions that we do see in pregnancy are urinary incontinence, pubic bone pain, round ligament pain, also called as lightning crotch, sciatica, tailbone pain, lower back pain. Now, commonly, I've heard people or doctors telling patients that all of these pains will, go away as soon as the baby's out. Come on, pregnant women, pregnant people, are humans. They shouldn't have to go through pain. They should be able to enjoy their pregnancy journey. So how we help them is either, take away their pain or help manage their symptoms to be able to function throughout all these changes that are happening throughout their pregnancy. And towards the end, we also do a very informative labor and birth prep, which everybody basically finds very helpful and definitely helps give better birth outcomes. Now, moving on to postpartum rehab, the way we can help people during their postpartum journey, either whether you have a vaginal birth or a C-section birth, you have to have postpartum rehab. Normally at 6 weeks, the 6 weeks follow-up with your doctor, you're basically cleared for everything. We highly recommend that before you hit the ground running, we would absolutely have you come in, get assessed. When you come in to see a pelvic health therapist for an assessment during your postpartum time, we check for prolapse, we check for diastasis, we look at whether you've had a perineal trauma. If you've had a vaginal birth, you could have urinary or fecal incontinence, you could have a prolapse. We check for all of these things, and we help you work throughout all these things so that you can be able to function at your best. Now, C-section births, right? So in the United States, the incidence of C-section is around 30%. So when you have a C-section, C-sections go through 7 layers of tissue. So when they're healing, the scar tissue that forms starts to cause a lot of stiffness and tightness of the surrounding areas. So definitely up into your abdominal area, down towards your pelvic floor, to the sides in your hips. So all of this does need mobility, does need strengthening, does need healing. So we can help you navigate through each phase of your C-section healing, as well as look for everything else that we would look for in for somebody who's had a vaginal birth. Now, these are some of the other things that we work with in postpartum rehab, helping you return to exercise safely, return to exercise postpartum. Moving on to pelvic pain. So pelvic pain is basically pain in the area that's underneath the umbilicus going all the way down to mid-thigh region, right? So this could be groin pain. This could be your tailbone pain. This could be pain with sex, as we discussed, genital pain, pudendal neuralgia. So the pudendal nerve is the most important nerve that supplies your pelvic floor. And sometimes when we do have a lot of tension in our pelvic floor, that nerve can get compressed somewhere along its path. So, which can be very painful. So that's something we absolutely treat. We treat endometriosis. We're able to help you with vulvar pain, with chronic pelvic pain, perineal pain, vaginismus, maybe post hernia repair, and so many more things, right? This is not an exhaustive list, absolutely not an exhaustive list. So if you do relate to any of these conditions, and if you do feel like this is something that you or somebody you know have been struggling with or might be struggling with, I would highly recommend you see a pelvic health therapist, and say you do decide to go visit one. This is what your first session with a pelvic health therapist would look like. So initially we start by, sitting down with you, taking a good detailed subjective history, having a great conversation with you, understanding why you're here, right? And then we move on to teaching you or giving you a good pelvic floor anatomy review, helping you understand how the pelvis looks like, where the muscles are attached, what other muscles are attached above and below it, and why, as pelvic health therapists, we want to look at all these other things, gives you such a better understanding as why we're doing what we're doing, and also empowers you to take control of your own health, right? Then we would do an internal vaginal examination or a rectal examination. But remember, you have the power to decline. You don't have to do it if you're not ready for it or if you don't want to do it. The reason that we would like to do an internal vaginal examination is to get a sense of the proprioception. We want to understand what your muscles are feeling like. What are they doing? Are they working in coordination with your diaphragm, with breath, are they strong? Are they weak? Is there any prolapse? We can get so much information by doing an internal examination. We also look at posture, breathing patterns, rib cage mechanics. We, again, look at areas above and below the pelvis. So important. And once we're done with the examination, we wrap up by discussing the hypothesis with you. We review your homework. So homework could be exercises. Maybe we would give you a bowel and bladder diary. Maybe we could guide you in using tools like wands, dilators if needed, any movement modifications, and so much more. So now that we've covered anatomy, function, and all of the different conditions that we could see in pelvic health rehabilitation, just wanted to summarize the basic benefits of pelvic health therapy, right? So we can have improved bladder and bowel function. That sometimes is underrated, right? Improved. How wonderful would life be if we can have wonderful bowel and bladder function? We can help you decrease pelvic pain. We can help you manage your chronic conditions, right? Sometimes those things are just something that you need to have help managing those symptoms and living your life. We can improve sexual function. Who doesn't want that? We can have better pregnancy and postpartum outcomes, and also improve your overall quality of life. So it's pretty fabulous. Now, how can you find a pelvic health therapist? We have three pretty easy search engines. We have pelvicrehab.com. We have the APTA pelvic health. .org. We have pelvicguru.com. These are wonderful directories to find pelvic health therapists around your area. And or you can just Google. But I will I think that's about it. And I'll hand this over to Jen, but thank you so much for listening. This went faster than I expected, but I absolutely enjoyed this webinar. Thank you so much for your time. I appreciate you.
You did great, Sheron. And that was like jam-packed with info. So I'm totally here for it. If you're watching this right now and you're already someone who is like pumped about the pediatric webinar coming up in July, those directories are not going to show you pediatric pediatric providers. The pediatric provider directory is actually not a public directory. So if you're someone who really needs a ped pelvic health therapists, email us. Just email us at hello@centralitywellness.com and we will search for someone in your area. But if any of this resonated with you, please find somebody. It doesn't have to be us, but because we're in the spirit of like just really loving all free content these days and like, taking things off, because you did attend, we are really hoping that if you want to see someone, whether virtual and in person, if you are close to us, please come to see us. Or you can have a virtual remote consult with Sheron or any of our other therapists, and we're going to take 10% off of that. And you can literally just scan this QR code for yourself. And then if you'd rather email, the email is also right here, hello@centralitywellness.com. And just when you're talking to Christina, who is our amazing front desk person, just let her know that you were part of this webinar and she will take that right off your bill for you. And then these are all of the pelvic health webinars that are upcoming. So today's April 11th, Pelvic Health 101 with Sheron. And then we have endometriosis coming up next month with Janelle and a guest lecturer, Kaylee Mitchell, Kaylee is amazing. Hello Endo Chick on social, so on Instagram. Male pelvic health with me and Sheron again. Sheron will be taking the 6th on that. And then as we said, July, we have pediatric. Then we have August 8th, role of pelvic health providers for birth. And then we also have lichen sclerosis in September with my friend Kathy, who runs the Lichen Sclerosis Support Network. If you want to get some LS content in soon, she has her Holistic Healing Summit is coming up in like 2 weeks. You should totally check that out. That's going to be amazing. If you're watching this recording after May, you missed it, but it'll come around again next year, but she's an amazing resource to follow. All right, so we have questions. I'm just going to pause for a second to see if anyone wants to say their question out loud before I start reading off the ones that came in to me privately and then also into the chat. Does anyone have a question right off the bat that they wanted to throw out to Sheron or to myself?
Oops.
Okay. All right, I'm going to rock and roll them with the first couple of questions coming in. Let me go ahead and get that open. So let's see here. Sheron, can you speak to normal frequency and regularity for urination and bowel movements during pregnancy?
That's a great question. Honestly, I don't think there can be a normal for that, just because think of where the bladder is situated under the uterus, right? So your uterus kind of sits on the bladder, and as the uterus is growing during pregnancy, there's tons of pressure on that bladder. So I think as long as we're not leaking, going to pee as many times as your body needs is okay.
And also, if you are in that late second, early third trimester and beyond, if you do not empty your bladder frequently enough, that can also stimulate Braxton Hicks as well as dehydration, right? So we typically see that frequency is going to change as you get into that late second, early third trimester. You may feel like you're peeing every hour at that point. It's also potentially positioning a baby in uterus on bladder. So some of this is just aim to be hydrated, aim to pee as frequently as you need to. Now, in terms of bowel movements during pregnancy, we would still, in a perfect world, really like to see that like once a day or like at least at the very minimum 3 times a week. Consistency is more important, right? So I really, just like Sheron said, smooth sausages, number 4s, like that's really what we want to be seeing. We do not want to be seeing any sort of like straining or discomfort.
Yep.
If you are having that squatty potty, like you definitely snag a squatty potty for yourself, and then maybe talk to your provider or find a pelvic health therapist to help manage bowel stuff.
Yeah, I would like to add to that, Jen. So when we do end up having to go to the restroom many times, especially when you're pregnant, your natural tendency would be like, I don't want to drink water, but that's basically not something that you want to do. You want to keep hydrating, because if there is remnant of urine in the bladder, it will get more acidic and make your bladder more sensitive and more irritated. So then basically the cycle of getting more urgency and more frequency continues. So the best way is to keep yourself hydrated. And then keeping yourself hydrated will also help with having healthier stools, because constipation is definitely something that we see during, sorry,
We have
the light
automatic
here.
she just has automatic lights on.
That's okay. So yeah, we have, so as I was saying, like we have a lot of constipation during pregnancy. So talking to your healthcare provider about possible supplements, maybe increasing fiber, all of these things can definitely be advised to you as a part of your program. I'm just gonna.
Yeah, you go ahead and move because our automatic lights at New Canaan want to literally stay off. There we go. Sheron, that actually leads into another question. Somebody dropped into the chat saying that they have urgency and they also have leakage. And because of that, they find that they don't want to drink as much water. How can they mitigate that? Since hydration is super important.
Right. I would say there is something that you can just try to give you a solution right now is the NAC method. But however, I would recommend that you see a pelvic health therapist just to see if that is definitely something that you want to do. But basically the NAC method is contracting your pelvic floor, and holding and stabilizing your lower abs, basically. But I would highly recommend that you actually see, like if you're having urinary leaking during pregnancies, most commonly during any kind of extra intra-abdominal pressure, so maybe coughing, sneezing, laughing, that's when you would use the NAC method to contract your pelvic floor before you would sneeze or before you would cough. I say that very carefully because we do not want to constantly Kegel, because Kegels are not for everybody. And that's basically, I've heard a lot of people being advised during the pregnancy, just go ahead and do Kegels so that your pelvic floor remains strong. I do feel like having an assessment by a pelvic health therapist will be the best option to help you navigate that situation.
Totally. And if you're trying to avoid fluids because you're leaking or you have urgency, it might be how you take your fluid in, right? It might not be if you're taking it, it might be how you're taking it in. If you're taking in too much at once, you're going to trigger like a flush mechanism in your system. Your body's going to say, ooh, we're flushing. So it's going to want everything to come in and out. So you may need to manage how much you're taking in at one time. And there's a magic number for every person that you kind of have to figure it out. I call it water math with my peeps. And so sitting down with somebody would be really helpful to do that. Okay, next question. When is the best time for someone to start PT while they are pregnant if no pain or they're not having any pain with their pregnancy, more of like a prevention?
I honestly would say as soon as you can, because we will guide you throughout your, give you a plan throughout your journey. So normally if you are having a symptom-free pregnancy, I love that for you. And then I would have you come in once every month just to get, there's definitely lots of changes happening to your body during pregnancy. So definitely helping you understanding exercises that we can do and anything preventative that we can do, work on breathing, because breathing is definitely going to be something that you want to hone in on because that helps prepare you for labor and birth. And then we do have a very informative labor and birth prep session around week 33, week 34, which is highly recommended. So once a month till week 33, week 34.
Yeah. And I would say if you are having a super symptom-free pregnancy and you want to be working on getting strong, there has been a recent article that just came out that showed that split squat, deadlift, squat, tabletop, like breathing core mechanics, those are some of the best, and bridges, there are 5 of them, are actually some of the best exercises that actually increase pelvic floor activity beyond a Kegel. So a lot of these things should be worked into that second trimester and even into the third. So those are the things that you want to be also thinking about. And you want to do that under the guidance of a physical therapist. So if you can get it in the second trimester, love it. Third trimester, for sure. Somebody actually also asked what a birth prep session entails. We're going to spend 45 minutes on that in August. That's one of my favorite topics. So I'm going to table that for now. And let's see here. Other questions. Are any of your services covered by insurance? Sheron, can I take this one? Is that cool with you?
Yes, absolutely.
So insurance is one of those things where it depends on who you are talking to, right? We are considered out of network, which means that we are not directly contracted with an insurance company. Basically, if you're in network, you do have a contract with that company and you bill the company directly. So for us, we have a rate that we see our people at. we can give you a super bill to submit to your insurance on the back end. If you have out-of-network benefits. If you do not, sometimes you can write a letter of medical necessity. But I would say if you're looking for a physical therapist, you would want to see, are they in network or are they out of network? If they are in network, what's your copay? What's your deductible? Because if you have a deductible that you're still subject to, you may get actually a bill in the mail that's more than just the copay. So you want to clarify that. If you want to see someone who's out of network, that's more of a flat rate. And then you want to ask, do they do super bills? Would you be responsible for reimbursement? I actually have an Instagram post on this. I will link it in this email that's going to go out with the recording that gives you all the questions to ask your insurance to figure out what's a better fit for you in network versus out of network. But we are technically considered out of network. All right. Next question for you, Sheron. Does the pelvic floor relax as we inhale and contract as we exhale in like normal functioning systems? And is there a way with verbal cues to assist this in like an outpatient orthopedic PT session, especially to help with pressure regulation?
Oh my God, I love this question. I love everything breathing, right? So when you inhale, your pelvic floor and your diaphragm move down. They descend down. You're not actively pushing down. Your body is designed to do this. Your pelvic floor and diaphragm move down as you inhale, and as you exhale, they do come back to baseline. Now, say for example, you're doing an exertional activity like working out or running. So you're doing a forceful exertion or exhalation. That's where your pelvic floor contracts even more higher than baseline. The next part of that question was cueing in an outpatient rehab. So in terms of like with breathing, and how we work.
Yeah. What type of verbal cues to your patients?
So normally when I cue breathing say I want somebody to inhale and help their pelvic floor descend down. If I don't feel a lot of movement within their pelvic floor, I just have them visualize either that there's a blueberry in their vaginal canal and that blueberry is going to just slightly slip out as they take a nice deep breath in. And as you exhale, that blueberry is going to be picked up by your vagina. You're not contracting so much, but that blueberry is just going to be picked or sucked back in as you exhale. I find that normally that cue definitely helps, but other things that you can do is, what else can you do in terms of moving your pelvic health through breathing? Jen, do you have any other cues?
Yeah, I would say a lot of people, they can mentally visualize, which is great, but I'm someone who's super tactile. So like when I started doing this and I had my own health journey, like what was that, 8 years ago now, I physically needed to be starting on my back in like a 90-90 position. So my feet up on like a chair while I was laying on my back on the floor and trying to do that breath, take gravity out of the equation. I also really love sitting on like a Corgis or like a soft ball or like a firmer pillow. So I can try to let my pelvic floor kind of descend into that. I find cueing in activity, like, you know, trying to have them inhale, lengthen, or exhale, lift in activity, it's actually really, really hard. And if you get them to master it in positions that are, you know, a little more focused, it naturally translates into movement. So it feels really boring in the moment when you have someone laying on a table with their feet up on a chair and you're like, okay, cool, let's work on your breathing. And I don't know how you feel as an orthopedic PT actually palpating externally over their clothes, like back near like glutes heel fold and like that vulvar area, but you can also feel that movement. But when they master that, they can then replicate it in their movement. So start with the boring basic stuff.
Yeah, I would also like to add to that, Jen. I don't like to cue a lot of belly breathing because when we belly breathe, I don't like belly breathing just because I feel like, especially when we see moms with diastasis recti or weak abdominals, right? So when you're belly breathing, all of that pressure is just going up in front because pressure is always going to follow the path of least resistance. And that way you're not really getting a lot of pelvic floor movement down. So you want to cue about 10% of tension in the abdominal area and more of that rib cage open 360 breathing, and then feeling that pelvic floor going down as you take that inhale in. Hopefully that helps.
All right, next question. Are there conditions that mimic a yeast or urinary tract infection, but when you get your test results back, these are negative for infection? Are there conditions that mirror like a UTI or yeast infection?
I would say urinary urgency and frequency. That would still feel like a UTI and you possibly don't have one.
Yeah, typically if your test results are coming back negative and you're feeling like you have a yeast infection or you're feeling like you have a UTI, there was someone else who asked a question about if IC is a tight pelvic floor muscle issue. The answer to that is yes. So like feeling like a UTI, feeling like a yeast infection, potentially having interstitial cystitis or painful bladder syndrome, those are all potentially signals that you have a hypertonic or a tight pelvic floor, which is giving that base of the bladder a lot of compression, and it's making your brain sense that there's something going on in the organ itself. So if it's coming back negative for infection, and even the person who mentioned IC, their question was, is IC a normal, or is IC a pelvic floor muscle issue? I went and had, they had a scan of their bladder, and they did not have Hunner's lesions, which used to be an indicator of IC, which is no longer an indicator of IC. So they were wondering if they could be pelvic floor issues. So the answer is yes to all of these. I would say if you're feeling this way, go have someone check you out, who's a pelvic health therapist at this point. You can kind of figure out, is it a tight pelvic floor? Can I alleviate my symptoms? Like, what does that look like for me?
Great questions. I love these.
These are great. All right, let's see here. Could you review what it looks like for pelvic floor therapist qualifications training and like red flag? So actually, Sheron, are you okay if I take this question? Because someone else asked something similar. Okay. So there's two questions here, and they're very similar. One, can we review the training of what a pelvic floor therapist looks like, and what are some red flags? And someone else asked, which this one was actually directed to me specifically, because I think this person follows me on Instagram, that they keep hearing the word pelvic PT, but we here keep mentioning pelvic OTs. And so they wanted to know our thoughts on occupational therapists as like pelvic health therapist, and how do we know who's a good fit? So let's answer both of these things. So occupational therapists and physical therapists come out of their grad programs with zero or next to no pelvic health education. So every single person that you find on that directory that you like search is actually someone who has taken additional postdoctorate or postmaster's training, which is great. It means everyone wants to go forth and specialize and learn. But that also means we're learning all the same things, right? So whether you're a PT or an OT, you're learning all of the same things to be a pelvic health specialist. We're both rehab providers. We both bring different things to the table. So I am someone who, that's why I no longer use the phrase pelvic PT. I do not feel it's inclusive, and I don't think that it is really good for the pelvic health OT counterpoints who are awesome. OTs and PTs get a lot of very similar information and education. And so that's my thought on pelvic health OTs. Now, in terms of when you're looking at the website, so say you go to pelvicrehab.com and you type in your zip code. Here we're 06437 in Guilford. So you type it in and say you get a couple of options for yourself. When you're looking at the directory, here are some clues to see if that PT or OT or therapist in general is going to be awesome for you. One, if they took a time to write a bio. So on these websites, typically you can either just like put your information in and like there's like no details about you, or you can actually spend time on your profile, write a bio, talk about the courses that you've taken, talk about your interests, talk about who you like to help and who you like to treat. That's an indicator number one. Two, there is an indicator on some of these that people have like different colors where they are like a PRPC, or they have these like extra alphabet letters after their name. That person, it means that they sat down for like an additional test afterward. And so that could be a good indication for you. I would truthfully say narrow it down to 3 or 4 people and pick up the phone and call them. Talk to them about your condition. I mean, I can't tell you how many times we call people on a weekly who just kind of want to like pick our brain to see if they would be a good fit for us and to see if we should refer them elsewhere. In terms of red flag, I would say if you feel like you're getting treatment that feels maybe that it's kind of cookie cutter, or like it's meeting everybody else, or it kind of feels a little bit more generic, or you're not getting enough time with your therapist, because sometimes the model of like busy institutions is like you get 20 minutes with your therapist and it doesn't feel like a lot. That would also be a red flag for me, because I can't do my job well in that time personally. But those are things to start thinking about. But when they're taking their pelvic health credentialing, they need to have taken a handful of courses, right? Pelvic floor 1, 2, 3, 4, right? They have a handful of things that you want to ask them, like, what courses have you taken? Have you treated my condition? How many people have you treated with my condition? What do you think? Should I come in? And they should be able to give you a good answer. Okay, one more question, and then we're going to wrap. Last one. When is a safe timeline to return to running postpartum? You just said 6 weeks is too early to do all the things. What do you think?
So there is actually a running screen. Well, let me backtrack. Depends on whether you've had a vaginal birth or a C-section birth for sure. With a C-section birth, it might take a little bit longer, but there are certain steps that we follow to assess individual groups of muscles to be able to tell you that, okay, you are ready to go into a high impact activity. So you need a lot of running is a single leg activity. You need good single leg strength, asymmetrical strength, which we tend to lose a lot during our pregnancy. And then going into postpartum, that's what we want to work with. And then building on that strength, we can assess and send you on your way to running, but it definitely takes time and patience. The return to running screen does include calf raises, hip abduction, single leg bridges, single leg squats, hopping. Am I missing on anything, Jen? There are definitely a list of things that we do look at with, and you should be able to do quite a number, like about 20 of each of these activities with good stability and pain-free. And then we would be like, yes, this is great. Is there anything else you would like to add to that, Jen?
No, I think that that's great. I also firmly believe that even if you aren't strong enough, that lacing up and going to run a mile, like probably in one fell swoop, might not be the best thing for the person. You want to find someone to work with to make sure that you're managing your pressure well and that you're not having any symptoms. And you might need to actually start with more of like an interval type of format.
Right.
You might need someone to actually look at your day pattern. I can't tell you how many times we've had people like either video themselves running or we take a video of them running and we want to see what it looks like, because once you get strong enough per the test, sometimes the function and what we see actually doesn't translate to how strong you actually are. So we got to get these like weird compensatory patterns because our
mechanisms, yeah.
And so we got to kind of work through the kinks too. So it's not always a smooth sailing as 6 weeks and free. I really would say 6 weeks is when the journey starts, and healing can take 18 months. So that whole 6 weeks, then like you're clear is nonsense in my book, like 18 months for when you can really start to like move your body, feel super strong, maybe get back to running, like intense type activities that you want to be doing. So patience is key. Any other questions before we wrap? The recording of this will be sent out. If you think that this recording would benefit any of your friends, your loved ones, forward the email. Like, this is free information. This is not something that just because you accepted, like you get to like keep it for yourself unless you want to, fine. But this is something that we want everyone to have access to. So please, 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 if you want to share it away. We are so grateful that you showed up. Hopefully you can come to next month, which next month is going to be with Janelle and Kaylee Mitchell, all about endometriosis. And that will also be sent out as well via the recording in I hope you guys have a great rest of your night. I'm Jen Morgan, Sheron Dsouza. She crushed it today. I'm so happy that she did that. And we'll see you guys at the next one.
Thank you so much, everyone, for joining. I really appreciate you. Have a good night.
Have a good night, guys.